here today. I just want to um, give a heads up. I was telling Aaron I might need to hop off around 11 and then come back on around 15 minutes later to have I have a conflict at that time. I'll be here the rest of the presentation for you. Yeah.
Okay, thank you. Okay, I'm going to share my screen. Okay, can you guys see this?
Yep, we can.
Okay. What? Okay. Okay. Hi, everyone. Here is my overview for my applied practice experience in my Talbot House internship, the experience I've had here, the research, and the recommendations that I have. So on the agenda today for the first section of this presentation, I'm going to highlight on my experience here, the background of the research center, the engagement center, medications and treatment options, objectives, SAMHSA, and an overview of mental health diagnoses. In section 2, I'm going to talk about my research questions, the data I collected, demographics of my data, my variables, my results of my testing, limitations of the data, and my conclusion. And in the third section, I'm going to talk about our new crisis center, medication and treatment options, my exercise science background, my exercise science recommendations for substance use disorders at the crisis center, and my references. So we are going to jump right into section 1.
Is that my problem or?
And risk factors associated across residential treatment facilities in the greater Cincinnati area. I critically analyzed and interpreted public health data using appropriate statistical tools and evidence-based approaches by applying epidemiological methods to settings and situations using computer-based programming like SPSS. I created and completed a research paper based on public health disparities within the community due to social determinants of health and well-being. I also worked with inpatient clients one-on-one and administered our GIPRA to demonstrate measurable results, promoting accountability and improving program effectiveness. And lastly, I was certified and completed CPR, CPI, GIPRA training, and iPortal data entry training. So here's a little background of the Talbot House and specifically the Research Center. The Center of Health and Human Services research at Talbot House is dedicated to advancing the understanding and effectiveness of behavioral health and social services. Through research, data analysis, program evaluation, the center works to improve the quality of care and outcomes for individuals in the communities, and our research helps inform best practices and guides the development of solutions to meet the needs of the population and the communities that we serve. So the Engagement Center at the Talbot House was created to provide a cost-effective and immediate 24/7 assessment and/or access to treatment for individuals struggling with addiction, especially those at high risk for relapse or needing withdrawal management. Specifically, its focus has expanded to those with opioid stimulant and substance use disorders of other kinds. This county building offers a 20-bed residential program with medication-assisted treatment options as needed. The center's mission is to help individuals reclaim their lives by connecting them with long-term community support. These programs may include buprenorphine, naltrexone, methadone, and comfort medications, which are agonist therapies commonly used to treat opioid use disorders, along with counseling services. Unfortunately, the FDA has not approved medications for stimulant use disorders, which will be more relevant later in this PowerPoint when I speak about my research. So here are two simple charts displaying the different options for medications for opioid use disorder at the Engagement Center pre and post the addition of our opioid treatment program. You can see here the most recent medication contribution was methadone. Level 3.1 and level 3.2 withdrawal management refers to different levels of care within the ASAM criteria, which is a set of guidelines for substance use disorder treatment. Level 3.1 is a clinically managed low-intensity residential treatment, and level 3.2 is clinically managed residential withdrawal management treatment. The main difference between these two levels lies within the focus of the treatment. Level 3.1 addresses a range of recovery needs, while level 3.2 specifically addresses the immediate need and experience of withdrawals. And the Engagement Center offers both. So some of my objectives and or goals for this experience were to learn and apply the CSTAT GIPRA instrument within intake and follow-up assessments on clients, conduct data analysis downloaded from the iPortal, evaluate mental health symptoms and relationships with opioid and stimulant exposures among men and women, and lastly, incorporate and assess social disparity factors that can contribute to substance use and mental health disorders. I am so sorry. I don't know why it's skipping on its own. SAMHSA is required to collect data on governmentally funded programs. SAMHSA developed the GIPRA in 1993 to monitor government performance. The GIPRA tool or the GIPRA document is to be used as a data collection tool on client activity and behavior to measure their progress in the enrolled program. The Tower House receives funding through the state opioid response grants and thus the GIPRA document to record client results. Additionally, in Ohio, selected residential treatment facilities have been awarded state opioid and stimulant response funding, which requires an intake assessment for all new patients admitted for services. As highlighted earlier, the GIPRA is a data collection tool used to evaluate the performance of federally funded programs and projects. The purpose of the GIPRA assessment is to measure the impact of programs and identify areas for improvement. So in essence, the GIPRA assessment is a comprehensive approach to program evaluation to ensure that federal resources are also being used effectively and efficiently to achieve desired outcomes. With this, there's a multitude of questions asked and answered on the GIPRA assessment when it's administered to clients. With knowing the background of the research center, the engagement center, treatment options, medication services available, and the SAMHSA overview, these factors assisted me with the creation of my goals and objectives stated on the previous slide. And outside of these factors, I was inspired to explore other variables from the GIPRA assessment that were not substance use related, and at the very least, the co-occurrence of substance use disorders, mental health disorders, and social factors that could contribute or influence addiction. So before I dove into the actual research I did, I wanted to get an idea of roughly how many clients that participated in our intake assessment reported that they experienced a mental health disorder. As I was looking through our Excel sheet that had all of our data collected over the past 5 years, I noticed that depression and anxiety were the most prevalent disorders reported and recorded. Here you can see there are 6 possible diagnoses of depression from our GIPRA intake. So in conclusion, 277 clients reported having 1 out of 6 types of depression disorders over the past 5 years. And over time, we have assisted 2,193 clients in the past 5 years, which I will talk about later in my research. But 277 divided by that number is 13% of our population or client population we've assisted has experienced a depression disorder. So additionally, you can see here that there are 8 possible diagnoses of anxiety from our GIPRA intake. This clustered bar chart displays the client's reported responses, indicating which anxiety disorder they did or did not have, distinguished by their sex code again. In conclusion, 744 clients reported to have 1 out of the 8 types of anxiety disorders over the past 5 years. And again, over time, in the past 5 years, from the iPortal data that I used, there was 1,993 clients that we assisted. And if you divide that by 744, that's 33 to 34% or 1/3 of our population. So to dive further into the basic charts that I created initially, here you can see a pie chart that displays all of the yes responses, indicating any of the 6 depression diagnoses distinguished by their sex code. Out of the 277 clients that reported 1 out of 6 depression diagnoses, the sex code was made up of 52% male, 47% female, and 1% gender nonconfirming. Here's another pie chart that displays all yes responses, indicating any of the 8 anxiety diagnoses distinguished by their sex code. Out of the 744 clients that reported 1 out of the 8 anxieties diagnoses, the sex code makeup was 49% male, 50% female, and 1% that refused to answer the sex code question on the GIPRA. Goodness. So after looking at this basic mental health data, this inspired my research project for this internship, which leads us into section 2, where I'll be displaying my research questions, my data that I collected, demographics of my data, all of my variables, my results, the limitations, and my conclusion. So research is important for understanding the underlying issues to properly address each disorder, especially the ones that I chose. So my initial research questions are stated here on the slide. My alternative hypothesis was individuals that underwent the intake GIPRA examination with mental health diagnoses, presence of depression, or presence of anxiety have a higher incidence of opioid or stimulant use, and in this case, I used specifically fentanyl and crack. And my null was individuals that underwent the intake GIPRA with mental health diagnoses, presence of depression, presence of anxiety do not have a higher incidence of fentanyl or crack usage. So for my data collection methods, I first obtained all of my initial data from the Excel file entitled GIPRA Report 1.14.2025 from the iPortal data file. The Excel file data was based on individuals from the Engagement Center, Parkway, and Peer Recovery Network. Individuals that participated in the intake were only eligible if they answered yes to one of the first 3 questions, which entailed opioid use diagnosis or history of misuse, stimulant use diagnosis or history of misuse, and or opioid overdose history. Initially, the number of interviews documented were 2,193, like I stated earlier. And next, I took out all interviews that were intake only, which left me with 1,803. And lastly, each client was removed from testing if they failed to report all variables, which subtracted 1,472 and left me with 331 for my final data set to use for testing. So the 2 dependent variables I chose were fentanyl and crack. The independent variables I considered were depression, anxiety, and mental health diagnosis. The mental health diagnosis was the only variable not measured by the number of days, and in this case, all of them were measured by past 30 days. And the rationale for choosing fentanyl and crack was simply in hopes of creating the largest data set possible in order to find some significance between any of the given variables. These 2 substances were the options were the highest recorded substances used from our clients who participated in the GIPRA in the past 5 years. And the next 3 graphs I'm about to show display the demographic makeup of the data set that I created. So here you can see a pie chart of the data set distinguished by their sex code. It was 62% male, 38% female, and 0.3 that refused to answer their sex code question on the GIPRA. Here is a simple bar chart displaying the data set by the client's age. The entire data set was ranged from 19 to 73 years of age, but the clients were primarily ages 25 to 61. And lastly, this is a bar chart representing the total GIPRA intake period ranging from November of 2022 to December of 2024. And the peak interview intakes were in February of 2023. So for my initial testing, I used a chi-square analysis. If the cross tabulations results show that the expected count does not equal the count, then there is an association. If the chi-square test shows a p-value of less than 0.05, then the association is significant. So you can see here, outputs 1, 2, 3, and 6 did not show a significant association. However, outputs 4 and 5 do show a significant association. So due to the significant associations found in output 4, which was crack days and depression, and output 5, which was crack days and anxiety, covariates were then considered to test the strength of these associations. And additionally, I chose to exclude the dependent variable fentanyl due to no significant findings from the initial testing with the 3 independent variables previously. So my alternative hypothesis was individuals that underwent the intake GIPRA examination with presence of depression, presence of anxiety, along with at least one of the 5 key social factors, have a higher incidence of crack use. And my null was individuals that underwent the intake GIPRA with the presence of depression or presence of anxiety, along with at least one of the 5 key social factors, do not have a higher incidence of crack use.
Kayla, can I interrupt with a question before I forget?
Yeah.
So you were talking about the chi-square results.
Yeah.
So when you were talking about the dependent variables, is that variable recorded in a number of days, meaning it is a continuous variable? When somebody can get a reported 1 day of usage, 15 days of usage, 30 days of usage, or is it just coded as 0 or 1? No, I use it in the past, or I did not use it in the past. I just trying to understand the data structure that is in this fed into this analysis.
You're fine. It was coded 1 through 30. I think 0 was never experienced it. So that was those were the only variables that were coded, not 1 and 2 or a negative number. And the number represents the number of days they've experienced that specific disorder in the past 30 days or the past month, I guess I could say.
Yeah, if that is the case, I'm wondering, the standard chi-square test might not be the appropriate best way to analyze the data, but we can rethink about it later today. I'm just if it is a continuous variable with more than one, it is not a binomial variable. I think the assumption of chi-square test will be violated in those cases. So yeah, I mean yeah, it's just a quick thought. Yeah.
Okay, thank you. So considering the need to want to see the strength of the associations, I chose to do some further testing. And after adding my 5 social variables, I chose to run ANCOVA tests. The 5 covariants considered were living where, insurance status, education status, employment status, and income. So for my ANCOVA test, my dependent variables was crack and my independent variables were depression and anxiety. Outputs 7, 8, 9, 10, and 11 showed that depression still had a significant association with crack usage. However, none of the 5 social variables had a significant association. Outputs 12, 13, 14, and 15 showed that neither anxiety nor 4 out of the 5 of the social variables had a significant association. Output 16 showed that anxiety no longer had a significant association with crack usage. However, income did have a significant association. So
Is
I
the
did.
so sorry. One quick question. So is the goal of the additional analyses to control for the influence of this covariates, meaning that you are trying to see whether there's still an associations after accounting for people with different living condition, insurance, education, employment status, or are you trying to also probe into the influence or potential effects of this covariates? I'm just trying to see what you think about this.
So kind of both. I did want to see initially if it strengthened the associations between just the 2 independent and dependents I had in the beginning. And then I was also interested if they might have had an influence on one or the other as well.
Got it. Yeah, thank you.
Okay. So I found some limitations in the data set provided. The first 2 are I was unable to assess which programs the individuals were from, whether that be Peer Recovery Network, Parkway, or the Engagement Center, and mental health diagnoses are all recorded on the GIPR intake form based on self-reporting, which could be deemed inaccurate. And lastly, the intake does not show length of stay, reasons for leaving, obviously, or the impacts of services provided, which can be further digressed by how drug use has been impacted after services provided, and or how presence of mental health disorders have been impacted after services provided. So for my conclusion, I cross-referenced the current running white paper available in the files on my work computer. The bold words are copied and pasted word for word from said running white paper. The specific goals I picked out from the running white paper align with my conclusion for my research. So considering that both anxiety and depression have a significant association with crack usage, it's possible that anxiety and depression may cause individuals to use crack as an outlet to cope with their mental health disorders. Therefore, it's pertinent that grant funding and access to these centers are continued to help identify those in need and potentially create other service routes over time to better assist with anxiety and depression disorders. Furthermore, it's crucial to maintain these services we provide so that eventually we are able to better understand these associations. This could lead to potential development of additional services more fit to the underlying issues at hand. Eventually, drug use and misuse can become more limited, along with unintentional overdose deaths, if we increase access and or enhance services that are adaptable to more than just one disorder. The clients represent more than just one issue, so tackling different disorders from multiple adapted angles would be more beneficial in order to reach the desirable outcomes we are looking for when it comes to the overall health and well-being of our community. Oh my goodness. It also does not help that there are no FDA-approved medications for stimulant use available, so tackling this barrier could also assist us and our clients. Again, I'm sorry this keeps skipping on its own. So this leads us into our final section where I will briefly discuss our new center, medications and treatment options, my exercise science background, and recommendations for substance use disorders at the new crisis center. So here are some pictures of our new crisis center located on Oak Street that should hopefully be fully renovated and open by July of this year. The facility will be operating up to a level 3.7 withdrawal management center, and this level care is appropriate for people experiencing severe withdrawal symptoms that require 24/7 observation, monitoring, and treatment in a medically monitored inpatient setting, but not as quite an acute care hospital level. And they will also be offering the same options for medications for opioid use disorder, as you can see here, that we offer at the other center. So a little bit about my exercise science background and why I think exercise could be an optional treatment for substance use disorders. Physical activity, specifically exercise, is a potential non-pharmacological treatment for addiction that targets systems implicated in both early and late stages of the addiction process and has secondary health benefits. Examples of that could be prevention of obesity and diseases such as type 2 diabetes. Mechanistically, physical activity and exercise activate the same reward pathways, such as abuse of drugs, through increase of dopamine concentrations and dopamine receptor binding. Levels of physical activity can vary highly between sports and between individuals, with results from one study showing that nearly a quarter of individuals participating in a team sport were not vigorously active. This suggests that team sport participation may not be a useful measure for level of physical activity or exercise, but on the contrary, this would make team sports a perfect match for clients at the engagement center battling substance abuse, because intense and or vigorous exercise is not recommended for people with these disorders. So in conclusion, non-vigorous exercise is a beneficial option for individuals battling substance use disorders because it can reduce stress, improve mood, and help establish healthy habits, all of which are crucial for a successful recovery. And it also offers a safe and accessible way to reduce cravings, again, improve mental health, and build resilience against relapse. Lastly, I just want to talk about some of my recommendations I have for our engagement center or any of the centers that we have in the future. So in this case, the crisis center. The client's schedule at the Talbert House centers consists of a lot of sedentary activities, which have significant implications beyond just health, impacting monetary lifestyle aspects as well. So, some recommendations for low impact, low intensity exercise options at the engagement center would be one, possibly create a monitored exercise room consisting of safe, gradual intensity equipment like treadmills, stationary bikes, and yoga mats. And two, possibly some outdoor activities, especially in the summertime. Team sport groups would be a great option as well, since it can be considered low impact and low intensity. As we've seen, there's not a lot of room in the courtyard. So volleyball and basketball would be great options and possibly cost effective. My mother had a substance use disorder most of her life. And when she was in prison, she was on the volleyball and the softball team. This was a daily activity that she participated in. So, considering people in the criminal justice system are able to have these services and activities, it could be possible to swing this for our clients. Lastly, the simple exercise routines can be something that our clients adopt into their everyday life. Once they are discharged from our services, it might encourage them to uphold their exercise routine, which can then be a long-term preventative treatment for substance use disorders that they can maintain on their own. And here are my references. Thank you for watching. Okay.
Great work. Yeah, that was excellent. I've always got a few things to say, so I'll be quiet until everybody else is done. Usually, when I get practicum students in, their final meeting, I try to get the preceptor to say as much as they can about job options and career development, and kind of summarize how their working relationship was. But in this case, since Allison wasn't able to make it, I invited her, but she said she's working on an overdose review committee for the health department and had a training she couldn't get out of today, so she was unable to make it. I will turn it over to Rachel for anything you have to say as her stand-in preceptor.
Yeah, great presentation. I love the edits that you made. I think it flowed really well, and you did a great job presenting with the notes that you had. In terms of job opportunities, like Aaron said, I feel like I'm not the best person to give advice on that, but I know we have talked a little bit about this, or I gave you this advice last week. If you're looking to do more community engagement oriented work, we work on an evaluation of quick response teams in Ohio. So especially if you're looking to engage that population with substance use disorders, that's a really good place to look. I know the Hamilton County team is always, I feel like, hiring their QRT navigator positions, which is direct involvement with that population and getting them connected to appropriate resources and treatment options and things like that. So I would always look to them, and obviously other behavioral health treatment providers in the area if you're looking to do more harm reduction work and things like that. But I think your next step too into that UC program will be really good for figuring out what your options are once you pursue that certification that we were talking about last week. So good luck to you. You're going to do great.
Thank you.
Since
I just got accepted, so I'm really looking forward to that, and I'm really excited.
maybe for Caitlin's benefit, Rachel, could you explain a little bit about your work in the engagement center and just what you learned from the talk that Kayla gave? Meaning, you've been in there and interviewed patients and done the work. And from my perspective, I wanted to bring Kayla in because in our first kind of advising meeting, she talked to me about her mental health, or sorry, exercise science background. And we talked a little bit about physical activity as an unmet need, I would say, of the engagement center. And that's something that I recommended to the center kind of formally years ago. And I don't go back to committees and recommend the same thing to service line directors that I find to be kind of, not listening to recommendations. But it is good to get, from my perspective, to get somebody new into the center doing that kind of work, interviewing patients and getting a new set of eyes on it. And she kind of reminded me that, oh yeah, that courtyard really should be better utilized. The way that they kind of focus so heavily on counseling to the exclusion of other kinds of therapeutic activities that might be good for clients, is something that really, I think, is a good point to land on in terms of final recommendations. But also the notion that we were so focused years ago when you were in there on fentanyl overdose victims and opioid, getting people access to MAT or opioid treatment, that I kind of forget about the crack and cocaine exposed clients that come in there. And over the years, those clients have grown to be, I guess, the largest proportion of clients, and they come in and don't have medication options. So really, physical activity and other kinds of non-medical options are the only things that they can kind of be provided with. So I don't know. I didn't know if you could explain, or just kind of say anything more about what it's like to work in there, and what you think about Kayla's perspective that might be helpful for Caitlin to hear.
Yeah, I would say I agree with you that exercise science background and perspective is honestly shockingly something that I never thought of when I was working over there. I think when you're in that setting, you kind of get tunnel vision and focus on what's in front of you and the work that you need to get done. I do remember having or raising concerns just with other people that I worked with over there about things like lighting, access to windows, you know, things like that. But exercise is definitely something that is super important and a really good option to have when you're going through something like that. So that I agree. That's probably the best thing that I got out of your presentation, Kayla, is that perspective of like, we have this outdoor space. There are cost effective options for, you know, being able to implement exercise into the routine for clients, even if they just to have the choice to do that, if that's something that you want to do, I think is really important. And it's a really good time to think about these things because of the transition to a new building. So I think that was really good timing. And I learned something about exercise and, you know, how it works with your brain and things like that. So that's probably the main thing that I got out of your presentation. And I think it's a really important perspective to bring up.
Thank you.
I wouldn't say good job, Kayla. You did great. And it's good to meet you, Rachel. I don't think, sorry, my camera's not on, but I've heard of you, so it's good to meet you.
Hi, you too.
I loved your perspective on the exercise and how to incorporate that. And I think that's something really unique that you can bring to your next program at UC is, you know, your personal experience with the topic, but also your background in, you know, now public health, but also exercise science. But I wanted to ask you, what was your number one takeaway from this whole experience? What was your favorite thing that you learned or gained?
Well, there were a few, which I wrote in my reflection. But to sum it up, I would say my favorite thing that I got to do physically was really work one-on-one with vulnerable populations. And I've only ever experienced these kinds of populations from a different perspective. So from a professional standpoint, that was super beneficial for me. I was able to understand how to navigate myself more in this realm. Usually it's always been family. So that's a little bit of a different dynamic for me. And I was grateful that I could leave emotions out of it. That was huge. And I was able to learn a lot more from these clients and from these people without having bias sway my opinion or how I am or how I act or how I think. I also learned a lot about these disorders as a whole and how vulnerable these people really are and how much help they need. I think that was my favorite, I guess I could say, empathetic learning experience because I was able to assist them, and that was really rewarding for me as for personal reasons, and that made me feel really good and made me want to come back and keep going and keep pursuing this internship. So that was probably my favorite part. Believe it or not, as much as I am not a fan of data analysis and SPSS, I really did learn a lot. Um, More than I thought I was going to. Actually, that was never my strong suit. And to be able to not only have the in-person experience, be able to show some significance between some of the variables that I had chose based on a bunch of different reasons, and then show what I could do to possibly assist this in a cost-effective way or a way that we could actually move forward without having too many barriers, I guess. That was really rewarding for me as well. I was really nervous today. Of course, I've been a total train wreck. I'm not against being transparent at all. I'm a very honest person. Uh, and I've worked really hard on this, but I know there's always room for improvement. I'm still learning. So I'm grateful that you guys can give me grace through my entry process into the public health realm because I really need it. And I look forward to this new program and my future here and where I'm going to be placed at in this community health world because I believe that with this constant and consistent, I guess, experience, I'm going to be able to make more of an impact on these underserved populations.
Yeah, great job. You've done a really good job. You should be proud.
Thank you.
I see Fan's back on. I'll kind of wrap up. Fan may have some, like a last comment or some questions, but I did want to kind of explain the next steps from our perspective, or the research, Tower Dust Research Center's perspective on, master's students in public health that come in, what they typically work on, and kind of what we tend to do on a year-to-year basis. So Fan and I, well, and Rachel and I as well, but for this project, Fan and I worked on an annual report that was late in coming out. And I'll screen share that for a moment just to explain kind of what I think we can do with this relationship moving forward. So, oops. All right, are you all seeing the report? Yeah, so last fiscal year, we wrote up the same thing that we always do. Well, at least I work with senior research associates and research associates on major projects. And Fan and I did, and mostly Fan this time, did analyses on our engagement center data set. And we found some of the same trends that I've found in prior years in terms of our focus on fentanyl and fentanyl combined with other drugs. And I tend to focus on those groups as the highest risk for death, coming from public health. And I guess we tend to focus on epidemic outbreak. And when I've had past MPH students in here, I've really had them focus in on hepatitis C and HIV screening rates in the engagement center because of the high levels of injection drug use. And then before that, we had MPH students focus on naloxone furnishing rates because there's such a high level of overdose death amongst the people who use fentanyl and heroin and some of these other drug combinations. But whenever we get in somebody new and they have a different perspective, it sort of can guide our annual report and maybe even our publication ideas. So in this case, I think we were looking back over a much longer period of time, and Fan created a few charts that extended back to 2022. And that's when we really, or the federal government opened up our funding to do GIPRA assessments on not only our opioid dependent clients and our opioid overdose survivors, but also our stimulant dependent clients. And that just really changed our data set in a way that enabled us to look at not only the fentanyl exposed and opioid exposed, but also the stimulant exposed clients. And so Kayla came through, like, I didn't really even recognize the fact that our kind of most common intake over this period of time was people that are self-reporting crack use. And we're going to look into refining our analyses and maybe correcting some nuances of the ways that Kayla was looking at the data. Van and I will help with that. But I think we can do some sub-analyses that really focus in on this group of stimulant users and sort of write up and characterize their relatively unique needs as they're coming through. Because as a kind of a morbidity, mortality focused person, I tend to think a lot about the fentanyl exposed people and kind of ignore the stimulant exposed people. But after listening to her analyses and thinking about the men and women that come through and the notion that exercise is an evidence-based treatment for people with anxiety and depression, I think we can do some sub-analyses that we'll put into next year's annual report at a minimum, and then maybe even write that up as an article. So anybody on the call who wants to get involved with that, we'll try to bring that back to this group for writing up at a minimum paragraph that goes into our next annual report, and then ideally an article. So yeah, and next year we always highlight our interns. So around next, yeah, we'll say the winter time, this coming winter, we'll publish a new annual report and have a subsection that includes an MPH intern again, down here at the bottom. And yeah, maybe we'll even come up with an article to work on together. So that's kind of how I see our year wrapping up. So thanks, Kayla. Thanks everybody for attending. And I guess since Van is back on, did you have any? You missed a lot of our summary, but do you want to speak to your what your experience was working with Kayla, and have any advice for her for the rest of her career, at least for the next year?
Yeah, great job. I didn't have any direct working experience with Kayla besides, we have a productive talk the other day when she dropped by. So yeah, I really have nothing to complain about, or you did a very good job. The only remaining maybe clarification I have about the presentation itself is that the property you talk about, you have 1,800 people, and then you drop it to a 300, and that means you are dropping out 1,400 subjects, and then you say that those who did not complete all variables are excluded. So maybe this is probably I will get a little, as a reviewer, I'll be a little bit, oh, you're dropping like 90% or 80% of the population. What do you mean by all variables? Do people who miss just one column of the data get excluded as well? Or do anybody needs to get all full 100% data to be included? Because a lot of your analysis doesn't contingent upon having full data. So this is my, or do you mean by, doesn't have variables that you need in all your analyses or across the data set? So this is something that I the only remaining concern that I'll make it clearer in the presentation. Yeah, with a data perspective. So
Yeah, that was probably one of the biggest flaws of the research. So the biggest issue that I had, and I think I mentioned this in the limitations, but I apologize if I didn't. I don't know if you listened to it either because I think you jumped off. But there were categories in the Excel sheet from the iPortal file that were just blank. So there wasn't even a negative number or a 0 or a 1. There was no value that I could use to represent what they said, and I didn't want to make up a value because that would be inaccurate. So what I meant when I said I excluded people if they didn't answer, I constituted a blank as a non-answer, and I needed all 5 columns to have at least some value. And even there was an option to say no, and I think that's the representation of 0, but there wasn't even a 0 in that column. So I couldn't make it up. That's not ethical, I don't think.
yeah.
So
Totally, yeah.
that was my reasoning. It's still not great, but I would rather have excluded them than made something up and been even more inaccurate, I guess I could say.
Yeah, no, yeah, definitely don't replicate, like don't cook any data. No, I think my clarification or question was, the full data has a hundreds rows, columns of variables. Yeah, I was simply wondering, did you exclude anybody who get a missing data on an irrelevant column get excluded as well? Or, you're just focusing on the 10 columns that you're using, and anybody who doesn't have values on them, get excluded. So maybe you are referring to that later. So I was thinking it might be the former, so yeah, that just has simply clarification, yeah, there's no encouragement from any of us to ask you to, hey, you should find a way to bump the data up, cook something numbers in the Excel sheet. No, don't do that, because this is the worst thing I can do it as a researcher. So in the future, down the road for your career.
Yeah, thank you. I appreciate all of your questions, honestly. Thank you.
Well, thanks everyone for attending and all the feedback, and again, good work, Kayla. And I guess I'll see you tonight for a drink.
Yeah. Okay. Thank you everybody for coming. I appreciate you guys taking time out of your day. It means a lot to me. And thank you for this experience.
Great job,
Bye.
Kayla.
Great
Bye.
job. Bye, everyone.